Oh, that's good. Afternoon, everyone. Thank you so much for joining us today, both in person and online. My name is Yuna Sidat. I am the Survivor Support Specialist at OIC. And we have a very interesting session planned for today, and I hope that all the information we share is really about being able to create awareness around the types of interventions and support a survivor of sexual and gender-based violence can make use of. We often find that survivors have this understanding of counseling as just sitting on the couch and talking, and then automatically that they'll feel better. But it's not always the case. And sometimes talk therapy is useful, but there's other modes, other types of therapies that may be more suited for where the survivor is in their healing journey, or what they're currently facing as challenges, and the type of support that they need. This is really to create awareness around the range of therapies and support that we can offer to survivors, or we can talk to them about. Knowledge is key, it's power, and it gives them agency to be able to make a decision based on what they feel they need. So before I hand over to our facilitator, Nazima Ahmed, I just want to recap and share a little bit around stats from our last year's SGBV Council report. And we received 138 complaints, and that is not only incidences happening in 2022, but also historic incidences. Survivors really just reaching out for support through the OIC. And from this 138, 79 survivors identified that they struggled with psychosocial challenges or had a mental health diagnosis. And from those 79 survivors, 53 of them received support from OIC, was at the point where they wanted to receive the support from us through counseling, containment, debriefing, and therapeutic support as well. So we're really wanting to create a shift in having survivors feel open and ready to seeking support, and to not see counseling or mental health as something secondary to the academic responsibilities, and not having that supersede their well-being and overall complaint. So thank you for joining us. I'm going to hand it over to the team.
And this of the binding is also psychologist and the East Technical Humanities. Welcome everyone in the role SWAT, who is the social worker at the same. Dr. Laurel, we have Claudia Gubner, who is the specialized wellness counselor at the OIC, Survivor Support Specialist and Case Officer. Dr. Rita Suleiman, who is a counselor psychologist, which is going to tell us about the forensic assessment of conditions. Welcome, Rita. And Sinclair Ilias, who is a counselor psychologist and is going to speak to the party R and WR team. Lots of things that help with the if you don't know about that. And then Zayan Fakir, who is a TRE practitioner and also a wellness mind coach and great. So welcome everyone. So the way we're going to run the session is that I'm going to ask each person to speak for 10 minutes. And I'm going to come to your 5-10 minutes for one. This for any questions or comments, or if you want to have a discussion rather than a formal presentation. So I'm going to move on to the next speaker, and so we're done, and then we'll comments, questions. What I'd like to do now, then before start, is to invite you to a sort of important mindfulness It's an invitation, so if you don't want to do it, we can, you know, jig the boat, but it's an invitation to really be present. We spend a lot of time kind of in this year, last week, last month, what happened in our past, and kind of giving ourselves a hard time about that. And what was in the future, like what's for dinner, what's next week, and we found this month. And we actually don't spend time embodying ourselves. We actually have a soul that is living in this physical body. And we spend very little time there. So I'm going to just take you through a short exercise. I'm going to ask you to, if you want to close your eyes, don't want to close your eyes, just lower your gaze. So it's just kind of the gaze just look down. And I'm going to ask you just to start by kind of sensing your toes. Just the fact that the big toe has got the most nerving sensations in your big toe. I've never ever done this before, and I'll say to you, just be careful. You feel into it. That's not really like really struggle with sensations, but really just kind of sense into the toes, sense into the rest of the foot. Up and move anything that's not far from curl, just feeling into the legs. Feel support of your bottom on your shin. The back is resting, if the looking at back of the chair or not. Now I want you to, way in which we become present is to focus on the breath. Yes, I want you just without doing anything else. You don't have to change anything. Just notice your breath. Going in, out of your body, and leaving your body just automatically. You don't have to do anything. Just follow it for a few breaths. Just to notice where are you breathing. Just notice as your breath going into your chest. And then over to your breath. Just notice where, how far are you breathing into your body. What I like to do now is I want you to try and take your breath to your belly. Right to your belly. So if you think of babies that are sleeping, their belly is going up and down. That's the kind of breath you want to get to. Breath. And when you exhale, I want you to try and exhale as long as and to try and have a long exhale. Just do it for a while. It's a good breath. Hold there. Just a little. That's how your body's feeling right now. Just a beautiful sign to actually back to your like now inside your body. I just put it on hold and just kind of find that to things. Okay, now I want you just to bring this to your feet again. To your bottom of the shoulder. The family chair is. I'm aware of the baby in the long again. You really. So I'm going to ask you to do this up today. This is statistics about it. Just notice if your mind goes somewhere else. Just bring it back. That's just the break is amazing. It's the only way to change if you do this. Your mind will, your mind has like be gone somewhere. So that's what mindfulness is. That's okay, so this up is Ronnie. Spoken about young men to minutes.
Sorry to interrupt. So we're having some audio challenges on the online viewers. So panelists, please project your voice not only to the people in this room, but far and beyond. Thank you.
Good afternoon, everyone. I'm Bonnie Krishna and as Dima explained, I'm the faculty of psychiatrist and humanities. I'm pleased to announce that we have a lot of psychology students in the room today. So welcome everyone. I'm going to give you a very brief overview about something boring PTSD and going to DSM-5. I'm going to share a little bit about the traditional narrative debriefing style. And I'm just going to talk about some coping mechanisms and interventions that could assist you if you are incapacitated and please bear with me. I'm in a little bit this lots to do, and I will try to finish on time. So as you know, PTSD is a psychiatric disorder. It's a number of things that stipulates when one is experiencing a cluster of symptoms. But the main four types that emotional autonomy, or the main four types that interest you are number one, intrusive, repetitive. So, we call that rumination. It's intrusive, it's repetitive, even when you don't want to think about it. It's really a
Sorry, I'm just sorry, it's all that.
Have
you called that? I'm just
intrusive.
Yes, but you said we called that
Rumination.
ruminations. Okay,
Rumination.
thanks.
Rumination is a key feature of depression and anxiety. All right, so intrusive memories, repetitive, causes a lot of distress, can be very degrading and very debilitating. Second is avoidance. The avoidance is one of the key features in terms of PTSD. The most prominent features are fear and avoidance be experiencing the trauma. And that is one very overwhelming. It's accompanied often by severe anxiety. So this apprehension, sense of dread, is ongoing tension, cumulative and build-up pressures. There's residual stress and stress. The third is significant negative changes in how you think, your thinking experience, and your mood, your feeling experience. That wasn't there previously. That's a significant negative changes in your thinking and your mood. And the fourth is changes in physical and emotional reactions, what we call reactivity, what we call spinning. In the language of psychology. There's quite a lot of severe emotional and physical reactivities. Don't worry about the DSM now, but just the core features. So to go all the way to the memories, maybe avoidance, your basic thinking, negative changes in thinking and movement, and changes in physical and emotional reactions. So, in terms of PTSD and DSM, there's only one stress required for a person to be officially diagnosed or have a verified diagnosis of PTSD. Right, so there's actual or threatened death, actual or threatened serious injury, actual or threatened violence or sexual violence. Okay, so in terms of that, to spell it out and to simplify it, how does it look and how does it feel in everyday living? What is the feeling experience and thinking experience? So it could be direct exposure to death, injury, violence, witnessing or traumatic event, right?
Sorry to interrupt. So on my part here,
Oh,
so we really have to project until we get another one.
All right, sure.
Okay.
So,
Now this is echoing also.
all right, so it could be learning that a relative or a close friend or family member was exposed to trauma, involved in trauma, experienced direct trauma, serious injury or violence. And it could also be indirect exposure, particularly those, I think there's a few staff members and students from the mental health field, a lot from humanities, those that are involved in mental health, voluntary work, those who are medics, mental health practitioners, etc., etc. So there's only one stressor that is required. Okay? We refer to picture psychodynamic with symptoms to surface. Okay. All right, now let's look at the intrusive memories. It's intrusive, it's excessive, it's repetitive. It might surface when you don't even want to think about it. You might be trying to avoid it, and it surfaces. How does it surface? In what form does it surface? What does it look like? And what does it feel like? It could be you might experience a survivor, you might experience recurrent, unwanted, distressing memories of event. Okay, so it's recurrent and it's unwanted memories. Okay, it might be living the trauma event as it was happening again in terms of flashbacks. Okay. It might be experiencing upsetting dreams and nightmares. Okay. And it's not unusual to have severe emotional distress and physical reactivities to triggers and cues, that reminded me. That smell, that sight, that sound, the place, people, the activity. So once again, it's, unwanted distressing memories, flashbacks, upsetting dreams, nightmares, and having severe emotional and physical reactions. It's cues, something that is familiar to the trauma event. Keep in mind that there is a huge sensory aspect of the trauma. And often survivors do everything that they can to avoid be experiencing, okay, because it is so threatening and it is so overwhelming. But okay. Thirdly, the avoidance of fear. It is not unusual for survivors of trauma and PTSD to do everything that they can to avoid the experiencing, being reminded of the trauma. And that's the challenge. It's when you go to therapy, your therapists are going to do everything that they can to help you break down the avoidance and break down the fear so that when you do re-experience a semblance of the trauma, you don't have such strong emotional reactivities in emotion. That when the energies in motion surface through therapy, through support, through entertainment, it's guided and it is not as threatening as it was previous. So if you're thinking, oh, there she goes again, you're thinking, I don't want to be reminded of it. It is normal. Okay, it is normal to feel avoidant, to feel fear. It's normal to want to do everything that you can to avoid any semblance of control. Okay, and lastly, there's often negative changes in how you think and how you feel. Right? So very simply, it might be feeling that focus about your future. Surfaces none, might have memory difficulties, remembering certain aspects of trauma, might have difficulty maintaining close friendships or romantic relationships, might feel detached from friends, family, might lose interest in activities you once enjoyed. You might have difficulty experiencing and re-experiencing positive emotions. All right. And lastly, might leave you feeling slightly numb, detached, with
At times in the PTSD, it experience depersonalization. This is really happening. B, or sense of derealization. Doesn't feel real. I wonder if it is. All right. It's fun to turn this up. Okay, all right. So I'm going to start.
Like, I'm sort of the conference, if it is something that you want to speak with the other person.
So very quickly, I did mention that in terms of the traditional narrative therapy, the most threatening aspect of debriefing or narrative debriefing is the sensory aspect of the trauma. You know, what did I hear? What I saw, what I felt, what I heard, you know, what I smelled, touch and feel, and narrative debriefing works in the sensory aspect for two reasons. Number one, the assumption and the premise is that the trauma memory gets entrapped and stuck within the five senses. And in order to release the trauma memory into what we call normalcy or normal memory, you've got to work, you've got to process, you've got to do and undo and tell and retell the story and the narrative to release it into normal memory. Okay. And once it is a normal memory, with the retailing and processing, okay, it is not as quickly and doesn't have the same strong emotional reactivity that it did once. So you take a hold that, you're the author, you hold the penmanship, you tell the story in a narrative style, retell the story, breaking down the memories, working five senses, so it becomes least quick. And in that way, you take control that, okay? You're able to process the memories, which now feels least quick. So I hope that helps. You know, both the TRE and EMDR specialists for more. Okay, that's it.
Thank you. Thank you.
Often. So just I need to speak louder. So my name is Melissa and I am a social worker at an organization called Mosaic. So Mosaic is, just very quickly, Mosaic is a training, support and healing center that provides a range of services to persons and families that is affected by gender violence. So I'm going to come from a slightly different angle. I'm going to share my experiences or our experiences in the organization where survivors come from. Okay? So firstly, most of our survivors, or most of the survivors, gender-based violence survivors, would enter our spaces at an elder. Oh. They enter the spaces at most of them are 30 years, 40, 50 years and older. So very few come to us in the 20s or in the adolescence or youth. And when we work with the survivors, when we work them on this journey of healing, the focus changes, and the focus is no longer the problem at hand or the challenge at hand, but past trauma that we have experienced. Those years of the emotions that they've been experiencing, and then keeping it with them. So, and I want to make an example. So, like 80% of our clients or survivors who come to our spaces, and they want us to help them with a challenge. I need a divorce. Help me through a divorce. I've been abused. I'm married for 30 years. I've been abused for 30 years, and abuse in all its forms. And we know the different forms of abuse. And they go through that abuse and they stay in those relationships and they stay in those marriages because one of the reasons, financial dependence. And when we explore why and how you find yourself in the situations, we are then taken back to the fact that because they haven't dealt with the trauma that they experienced or witnessed as a child or an adolescent, they haven't spoken, they haven't reached out for services, they kept it with them. That those experiences hindered them and contributed to the fact that they could not learn at school, or they, like they say, they dropped out of school. It contributed to them making negative choices. Couldn't finish matric, couldn't study further, cannot. No, could not find a job, employment, so they couldn't be financially dependent. Find themselves in situations where they had to or have to sacrifice. So I want to urge almost, I want to advise you, people that you know that are going through challenges, that are going through traumatic experiences, speak up, speak out. The services are there. We just need to reach out and grab that opportunity. We're now not only working with the adult woman or adult man or this adult person, but we're not only working, not only does that person have to go through or work through what is currently, what is the presenting problem at hand, but now also have to work with past years of experiences that that person has to carry with them, and not only try and heal themselves, but their children, because now their children have experienced and witnessed the abuse of the survivor. So that's what I want to share. Impossible.
Okay, thank you. Thanks so much. And now, thanks. It's talking you now.
Firstly, apologies for the sound online. We are trying to speak as loud as possible. I think it's probably easier if I stand up and project. But yeah, I'm going to be sharing my experiences in terms of working with survivors at UCT, both UCT staff survivors and student survivors. And the approach that we use is survivor-centered, meaning that we follow the principles of empowerment and we trust that the survivor will guide us in what's best for them. Now, when we're looking at the psychosocial aspect of the well-being of the survivor, Some of the challenges that we see survivors experiencing here is that there's a great sense of pressure that they feel they need to focus on the academics. There's a great sense of pressure to not take up support because they need to get through this exam or they need to get through this assignment. But on the same hand, with that pressure, you also need to understand what happens to a survivor when they experience sexual or gender-based violence. Their power is taken away from them. They are left with no sense of control. So they are really looking for different ways in their everyday life to find a sense of control. And that's where we find ourselves, or I find myself in a tricky position, because yes, I want to make things easier for the survivor and say, I can give you a letter and ask for an extension. But that's what I'm thinking. That's my bias. That may not be what the survivor needs. In that survivor's mind, taking that letter means the perpetrator. The perpetrator is now given their life. The trauma has overtaken their everyday life, their everyday functioning, and they don't want to see that by taking this letter of support, that it's a way of them not being in control. Sometimes that is what we practice, is that a survivor sees support as something to reflect that they are weak, or that they are broken, or that they are essentially experiencing emotional turmoil after trauma or post-traumatic stress. And that is very loaded. That is a big thing to sort of process and to recognize that your thinking, your being, your mood, your appetite, your functioning, everything is changing. And what would that make you feel like if everything is changing and you don't want it to change? You feel like you're not in control. And so it feeds into that thinking and that what they are sort of, what we see in rape culture, that is, you know, the survivor is weak, or that the survivor didn't do enough. And so what that is doing is feeding into the negative narrative. And so as much as support is helpful, we need to show the survivor that if you take the support, it doesn't mean that it's weakening. It means it's giving you agency. It's giving you the time to heal. It's giving you the time to focus on you and what you need. You know the saying of you can't pour from an empty cup? It's literally that. Survivors feel so focused on academics or going back to their regular schedule and their normal socializing. But all that does is that it could be making it even more difficult for the survivor to connect with themselves. And we know from what Vivani shared is that there's a lot of disassociation, there's a lot of, finding ways to distract themselves. And it's sort of a catch-22, because sometimes that exam or that test is going to help them get through the day. But on the other day, it's not going to help them get through the day. It's going to make them feel even more vulnerable. And so where is the balance? And I think the balance is by normalizing that taking up support in whatever form it may be is okay. It's putting yourself first. It's your courage. It takes a lot of courage to speak about your trauma. But you're already speaking about your trauma as a survivor most of the time when you get to that point. And it's about saying, if you are talking about this trauma and what you learned through, how do you talk about it in a way that benefits you? Because just venting and venting and venting is going to make you feel, or make the survivor feel like they're stuck in a loop and that they're not feeling any sense of relief. And if anything, they might feel more frustrated or more trapped in this trauma. So how do we help guide a survivor to alleviate that? That's through the different types of support. And so at the OIC, what we offer is counseling. We also offer educational interventions with sort of working with me, understanding psychoeducation. We also have a survivor support group that runs each week. We also have a clinical social worker and counseling psychologists who can do evidence-based learning as well, in addition to what student wellness does. Because there's sort of this, perhaps even this misconception that you'll go for therapy and you'll be fine. But it's not. This type of trauma shapes you in so many ways as you enter into new chapters of your life. You're never going to stop learning about yourself as a survivor. And so if you supporting your friend and you're friends with this person for 10 years, you may find that in that 10 years, they'll be redefining what they understand themselves and how they understand themselves to be a survivor in different chapters that they go through. And really what we've been hoping is to say, take up this and take it up when you're ready. But let us not leave survivors in a vulnerable position where they're experiencing these challenges but don't know who to speak to or what support is available. So if you know of a survivor, start having these conversations with them. Start normalizing. How are you coping? They don't have to tell you what happened to them. They don't need to tell you every week, that they're battling or every time they're having a difficult day. But normalize the conversation to say, even though we don't have to talk about details, how are you coping? Have you been having a good month? Do you need a little bit more support this week? Because sometimes the friends and family members are a crucial point of support structures. It's not therapy, and it's very important also for survivors to recognize that for you as a support carer to say, I'm not a therapist, I'm not a counselor, so that the relationship doesn't become one-sided of your friend always telling you how they feel, or the survivor feeling guilty or feeling like they're burdening you by telling you how they're feeling all the time. So you really also have to find that balance as a support carer or as a survivor, to let in your friends and family, to let them know what type of support you want, and as a support carer, to let them know what support you can offer, and bring into the conversation, would you like professional support? UCT offers free support. If you don't want to go through UCT, you have financial means for private therapy. There is support, and we need to understand when these different types of support is possible or when it's needed. But really, I mean, just to, how much time?
20 seconds.
I mean, survivors I see survivors at different stages. You'll get a survivor who's in a phase where they're really testing their reality and their world and looking to make sure that they feel in control of everything. And they may not be ready to speak in that stage. On the other hand, we find survivors they start building up, and they start recognizing, well, there's been a significant change in what I do every day, or how I'm feeling, or that I'm not able to perform academically like I want to. Then they may go into a state of anxiety and panic. And then they feel like, what's going to happen? Like, my life's going to fall apart, and they reach out for support, right? And that's okay. And what we need to look out for is that panic and fear temporary just because they've had this realization and so we will put them through that? Or is it where they're functioning so incapacitated for a long period of time and then they need to be looked at referral for a psychiatrist in inpatient programs, long-term care? So it really is so much, but really at the core of it, the message I want to leave today is bring this into your conversations, bring mental health into those conversations with your friends, even if they're not survivors. If we start talking about it, it becomes a strange and foreign. And survivors are looking to feel connected. You know, the only time I think survivors feel connected is in a protest. When there's anger, when there's frustration, when there's hurt, when there's betrayal, when there's loss. Let's start shifting that and create the connectedness in terms of their well-being when it's not a crisis and it's a long-term crisis.
My, my, my field is a little bit, I think, tied in with what Linda said about what's available to you. But mine is not in the therapeutic field, mine is in the forensic field. Now, you hear about forensics and you hear about therapy, you want to know what's the difference. Obviously, therapy is the support that you get to work through treatment. Like Bhavani mentioned, Nicholas mentioned, and forensics comes in when you decide that you want to take the matter further legally. Not just for university, but on a legal, you want to actually report your rape or violence, whatever it was. You want to report it, you get a CAS number, get an attorney or the prosecutor acts for you, and they would call upon me to do investigations, forensic investigations. Yes, therapy does enter into the process, but in a very small way. It's more for containment than it is therapy. And I'll go through that. People are always asking me, how do you study to become a forensic psychologist? Well, sadly, it's not even a category with the HCSA at the moment. And the way that I could get into the field was I met with the HCSA and they said, after you've worked with legal experts, get references from them and bring them back to us. And we will then decide from the references how you're working and we'll monitor some of your cases. Now, fortunately, we have courses in forensics. You can get perpetrator identification, profiling, you can do all of that now. But I did all of that in my experience and in some of the short courses that I did. And when I went back to UNISA to do those courses, they said I'm not allowed to because I've got experience. And they wanted me another degree because I didn't study for the degree. All right. What does the field do? It takes care of finding out the difference between he said, she said. That's what happens in court. It's no, she did this. She did not say no. He did not say no. She told me she wanted it this way, and that's what I did. So when we start the process, we need a directive and instruction from a legal practitioner. So you would have already reported the case. You would have already gotten a J88, which is done by the Surgeon General, where they will examine you like you see on the TV programs. What's that? SGBV. You see all of those things where they collect rape kits and all kinds of evidence. Now the J88 is actually an outline of a human being, can be male or female, and they will mark on there, they'll do an examination from head to toe and find out and mark on that diagram what are the injuries they observed. Right? That becomes now part of the evidence bundle. When you
get a trivial question, you can't, for instance, come to a forensic psychologist and say, I need my case investigated because of X, Y, and Z. It won't work like that. Because the court will ask you, where's the impartiality? You've been told by the survivor that they want to be tested and heard in court. Then you go to your psychologist or psychiatrist and ask them to represent you in court. The other thing that we can do as forensic psychologists, we become witnesses for the state, which is a long process. And I've just become expert with this state at the moment, where they could then refer cases that if you go to legal aid, remember that option is open to you. You go to legal aid and you say what has happened to you. They then take your case. And then the legal aid is a sub-branch of government, which will then put out a tender for a forensic psychologist or an expert witness. And that's when I come into the picture. But a lot of the times, people get the legal representative to approach me. The process is the first part of the process. There'll be lots of legal documents that have accumulated, medical documents, legal documents, whatever. The forensic psychologist has to do what we call a discourse analysis. That is the only point where every single piece of paper is examined and read. So it kind of gives you an overview of your mind as to where you want to go with this case and how you want to approach it. And you obviously have to be totally objective. I know when you say objective, it's kind of like our experiences guide our observations, don't they? So we sometimes get our experiences from other people. So how objective is that? Okay, but I'll read you a quote at the end, which will hopefully make sense. The investigative process, you outline it at the beginning. Documents are sent to everybody involved in the matter. For instance, your parents or grandparents or family members are affected by what's happened to you. So you need their input, and that's called collection information. Sometimes you have to sit with them in a kind of interview process. And you also decide what formal assessments you're going to do. I can't go to court and say to the judge, the magistrate, my gut tells me this. It's going to say, take out your gut and show it to me. No? And so you've got to do assessments. I do a battery of at least 5 assessments. It's also dependent on what kind of case it is. Okay, you could have a child family law matters, which is like custody. And you guys, I don't know whether you're aware of it, but there's 2 syndromes in divorce that relate to gender-based violence. The one is called the allegations, it's sexual allegations in divorce syndrome. And the first one, that's the second one. The first one is parental alienation. So the one parent tries to alienate the other parent by saying different things. The second one, if that doesn't work, the second one is sexual allegations in divorce syndrome, which is SAIDS, where they will actually come to you and say, this parent did that. I had a case where a little girl, she was about 6 at the time. And whenever she went to dad, when she came back, mom would squeeze orange peels into her genitals and make it all red and miserable and put mercurochrome on her underwear. And then take it to the police at 4 o'clock in the morning in the same party dress that she wore at 3 o'clock. So nobody else does that kind of linking like the forensic psychologist. Uniformity in process. If you're dealing, for instance, in that kind of scenario, whatever test you're doing with one party, you have to do the exact same with the other. You've also got to administer it in the exact same protocol or whatever you call it. And all of you, I don't know what level you guys are at, but you know that most tests have a lie score associated with it. So immediately, that is the first thing we look at. What is the lie score? And if it's common amongst like at least 3 of the tests, you know something's going on. Okay. Spoken about collateral information. Recently, studies in America and Australia have shown that when it comes to somebody reporting gender-based violence, they get the alleged perpetrator in as well to hear both sides of the story. So when you're doing the assessments, we do it on both people as well. Okay, I spoke about the holding space for clients in the process. I work on a system called the 3X principle. I'm actually getting it currently tested to be approved by HBCSA as one of the assessments that we can use. That's the first F is for the facts of the situation that occurred. The second is the feelings that Vani mentioned, all the sensory aspects of the incident. That's the second F, the feelings. The last F is the future. How are you going to use the first two to help you develop? So you're carrying kind of lessons from the incident and not the baggage of the incident. Okay, so I'll actually share some of that. Boundaries. Although you're offering that holding space and therapeutic space, you cannot cross the boundary and say, okay, so the next session we'll do and that we do, we're going to go through all your feelings and we're going to try and get you to normalize. We don't want you to normalize at that pace. If you're going to be on the stand, we want to hear you. Because if you sit on the stand and believe me, I have sat on the side of the state when they're busy doing an investigation in a case on murder. And somebody else had already done an assessment on the defense's side. And I read through the report and I said, I'm not doing any assessment. Let me sit with the prosecutor and I'll guide you in how to question, cross-question. Because the person pleaded temporary amnesia. That's a big one that they will say. I didn't know what I was doing it. Right? And I actually found loopholes where we could get in and say, you couldn't have done it. Because directly after that, you did X, Y, and Z. Okay, so you've got to be sure that you know the case in and out. And it's your duty when you report to make sure you report all the details. Okay? I also made a note that we've got to be careful about regionalization. Okay? Like all the speakers so far have spoken about the narratives, what you're feeling now, what you need now. You don't have to go into tell me exactly what happened. That's not lawyer's job. It's not ours. Okay. Then you've obviously got to write a report. Reports ranging anywhere from 150 to 300 pages, where you've got to list everything that you've done in that case to show total transparency. Okay, the report is not given to you directly. It's given to your legal team when they need to discuss it with you. They call the forensic psychologist in case there's any questions that they don't understand. There's a support. Okay. Okay, the other support structure that comes in, are all of you familiar with CBT? Cognitive behavioral techniques. Okay, or therapy. We've gone one step further now into DBT. Do you know what that is? Okay, it's changed. CBT is changing your thinking process. DBT has taken it one step further. When you change your thought process, what do you do to change it? It's the doing part. Okay, read up if you can on the STOP skill and the TIP skills. Okay, that helps quite a lot. And then I just want to leave you with these two quotes that I found. And one is, I am not what happened. I am not what happened to me. I am who I chose to become. That's by Carl Jung. Which does say simple things sometimes. Okay. This one is by Eleanor Roosevelt, who's one of the old first ladies of the United States. She says, do what you feel in your heart to be right, or you'll be criticized anyway. Okay, thank you. Like I said, thank you. Like I said, DBT is changing your cognitive processes into active processes. Like somebody says to you, just think of something else, but they don't tell you how to think of something else. Nazima did something called mindfulness just now. And that's the basis of DBT. To be in the moment and how you're going to feel in that moment. So you bring yourself to the here and now. And if you can't control your thoughts from escaping, there's techniques that you will use that help you do stuff, that helps you to normalize. Each one has different things that they would do. I do something, if you want to try it, you can put your hands high up like this, both in front of you. And imagine that there's a transparent filament in between your hand. If you're focusing on your hands at the moment, you'll already start feeling a throbbing sensation in your palms. Right now, I want you to leave the left hand where it is and press slowly, trying to compress, very slowly, trying to compress with your right hand and try to flatten that filament and focus only on that process. And go slowly down, but don't touch. Focus only what's happening on the palms of your hands. And slower, slower, and you should be feeling some. Focus only on the element and try to flatten it on your palms and feet. Something sensation. Anybody felt it? Yes, you didn't feel it. You can actually bring your mind to something as simple as that. And if you're just focusing on that, that's a stop spin. To stop your mind from wandering around into what would have, should have been. And when you finish, you actually feel like, wow, I could do something with my body. And you get your power back in the stages like that. I don't want to go too much into it because DBT skills involved.
Thanks so much.
Thank you.
Thank you, Lisa.
Yes, I always want to break the ice and say to students, 200, 300,000, 3,000 word essay that you've got to do. That's easy, right? Compared to 150 pages of report. So get used to it. It's actually a blessing in disguise. I know when you're swearing us with lecturers, that is mentally, that's actually a good exercise, hey, to take into the future.
Like you can even do that exercise if you're stuck in an essay on the exam and you want to regroup because you say, I studied and I get into that room and everything is gone. Just regroup and do something as simple as that.
Thank you. Yeah, it's really, and it's the can see us as like the MTR. Okay, hello everyone. My name is Samiha Elias. I'm a counseling psychologist in private practice in the southern suburbs. I recently moved to Cape Town because of BWR. I have a special interest in trauma and EMDR stands for IM desensitizing reprocessing therapy, and BWRT, different therapies, stands for brain working recursive therapy. Both were created specifically for PTSD initially. They both are not talk therapy. So traditionally DBT, CBT, cognitive therapy will be involving lots of talking, telling your story, doing some skills, distress tolerance, mindfulness, that from DBT, CBT, working with your cognitions. BWRT and EMDR don't work that way. They are very brain-based. They're very neurobiological. EMDR works with bilateral stimulation, which means we activate both left side and right side of the brain, and this is done using eye movement. So while we're reprocessing the memory, you're trying to follow your finger going up and down, or you do butterfly tapping, just smoothing in itself, just doing that. Or you put that on your knee and you do the same thing. Left and right, left and right. The reason for doing this is it helps to process the memory. So when we encounter traumatic experience, our brain stores the memory, the picture, sounds, sights, everything, feelings, thoughts, and it all gets locked in. Body sensations, everything gets locked into our brain, the whole picture. EMDR, through bilateral stimulation, allows the brain to reprocess these maladaptive memories or emotionally reactive memories in a more healthy fashion. It is similar to when you go to sleep and you go into REM sleep and start to dream. You really dream about what happened in the day. So your brain is now finding away what's happened, processing everything, coding it and putting it into its existing files. EMDR works similarly, where we now reprocess not only that traumatic, but all the past or the past memories that are on the same neural pathway, all will get processed. Sometimes you find that clients come to you and say they have this trauma right now, this is what happened to them, and then we find a target memory, a visual memory that's linked to that. We process that, and all of the other ones on the same neural pathway tend to become better. How does this work? This works because your own brain does the work. So you are in control, it's very client-centered. The psychologist is there as a facilitator. Research has shown that EMDR and BWRT both are very effective in reducing PTSD symptoms. So up to 84% of people can have no PTSD symptoms after a very short EMDR process. So it's not like talk therapy. It's much quicker, 2 to 3 sessions it would take for EMDR, maybe 4, and your symptoms would reduce. All the symptoms that Pavan spoke about, the activity, avoidance, hypervigilance, intrusive thoughts, all of those things will get reduced if PTSD has been developed. The most important and impressive thing about this therapy is that if we do it immediately, if a survivor comes to us and they want this therapy, trauma is recent, we do this therapy, PTSD doesn't even develop. So we don't get to PTSD symptoms, we don't get to all of those avoidance and those coping mechanisms. Remember, trauma is stored in the brain, it's also about connectivity. So once we store it in the brain, we disconnect from ourselves, disconnect from our environments, disconnect from our studies, disconnect from other people. And then PTSD symptoms become a coping to what our brain is trying to process. But if we start before that, then we don't even have to get into PTSD. We don't get to PTSD, we can heal the trauma, we can make it better before that. And let me tell you a little bit more about BWRT. Brain working recursive therapy also is brain-based. The simplest way that I can explain this to you is it's like upgrading your cell phone. And so now when you get on your screen, oh, this is new software, and you're like, yeah, okay, download tonight, yay, wonderful. You plug in your cell phone into power and Wi-Fi, whatever it needs, and then the new software is downloaded. The next day you get new emojis and things are happening, phone is working better, nice, that is greater, whatever. There's editing messages. You forget about what happened before. BWRT works that way. It works before the actual time. So when we store memory, traumatic memory, our earliest brain, the part of the brain that's developed the earliest, it stores the information, but it doesn't do it with judgment and emotion. That comes a little bit later. I remember to do this experiment and found that there's a lag from when we store information and then it goes through our awareness and then we react. There's about half a second that happens in. This is essentially where BWRT works in this lag. What we can do then is, what happens this time is, we get the information, our brain being the wonderful organ it is,
it pattern matches. Oh yeah, this happened. Therefore, okay, this is the reaction. Half a second it takes for that to happen. Like phobias are formed this way. See a dog, freak out, terrified. Okay. Next time I see a dog, oh yeah, I remember that thing. Dog, freak out. Our brain does it automatically. Now a dog and freaking out is pattern matching because our brain works on pattern matching matrix. What BWRT does is this. Here's the dog. In that half a second lag, I reprogram, I update something. I give it other options, other patterns that we can match to. So now when I see a dog, okay, dog is doing dog things, dogs are not dangerous, dogs are okay. I do all of that, and that's in the process of BWRT. So I don't go to pick out, I go, okay, this is manageable. The best thing about BWRT is I often have clients who come to session and like, don't you have a magic wand? And I don't have to be here all the time, I don't talk about this. And I go, oh, I think I'm in just. And I say, okay, let's try this and see. And then we do BWRT or EMDR. BWRT works quicker than EMDR, that's impossible. Works in 1 session, 2 sessions. BWRT on that specific traumatic memory. Immediately after that, we don't change the memory, can't forget. Happened. But the emotional experience is much more reduced. So it becomes your story. Both these therapies, it becomes your story. It happened, but it's not, oh, I can't live. I can't write that test. I can't do my exam. I can't go there anymore. I'm only hearing this. It's not that. It's your story. Yes, it will always be your story, but you're not trapped by it anymore. You released it. EMDR works voice sensations as well. Scan your body and find where it's stored there and do a separate thing with that in the process. All of that becomes a list. BWRT and EMDR have been used internationally. I used it, both of these therapies, recently with the first responders who went to the Turkey earthquake. It's been done internationally or in war zones, in natural disasters. And research has shown that those people who were exposed to, when it happened, they had group EMDR, when it happened and they had this therapy, those people who had this therapy was those who didn't go on to experience PTSD symptoms. But those who didn't, eventually had PTSD symptoms, and then we got to think, when is this useful? So, most important to remember about these therapies because it changes perception. It changes your feeling about it. And as Rita said, you don't want to do that. So, if you're reporting, you are in a legal battle with this, or if you're going to take this further, containment, what we advise you to do, and when you have seen the process to do, then we advise you to come to us. But then we make it better. Because this makes it better immediately. You go on the stand and you're going to tell a story. Oh, this happened to me. And then it was be like, oh, really? You're okay with it? It's not going to affect. Because that's how quick and efficient these types of therapies are. So you're going to say, this is the word useful. If you're not reporting, he will help you immediately because it makes you feel hopeful to tackle life again. That's what it does. And if you finish the process, you often have to do this therapy is not only for the trauma, but the re-traumatization that occurs as a result of the therapy process. So it works for both therapies. Another thing to remember that with these type of therapies, it doesn't matter how long ago the therapy or the trauma was. It can happen when you were 5, 15, 10. For these type of therapies, the past is the present. What we do in these type of therapies is we activate those neural pathways that stored this entire event. So once we activate it in the here and now, it's almost like you're re-experiencing it right now. It feels that way. I see the angst. I see it. Yes, it's very terrible for a few moments, but then it becomes better. And through that, we reprocess it. So what happens when you were 5, 10, 15, 20, all those past traumas and how they affect you, as Mo was talking about, we can process each of them, do this type of therapy, and we heal each of those traumas that makes you function better in the world, to tackle things. So it can help survivors today, it can help you from past trauma, all of them that are still in the same. So that's my magic one. It just helps those people who are just tired of talking. I have some clients just don't want to talk about it. They've talked it out and then debriefed and they've done it and they've spoken to people and everybody wants to know the story. Recently had a client who had a house invasion. And it's fine because initially in the first 2 weeks, she was still in fight or flight. She came to see me, she was like, everybody wants me to come here, but I'm fine, I'm okay. And then I told her family, please watch her because Cash doesn't come. And he came about 8 days later. So she just had a flashback on something and completely crashed. I saw her 2 days later, twice, and never seen her. That's the reality in a nutshell. So there is hope. You can get better. You can live your life. Get the support you need. It helps you to become functioning in your world, to become connected to yourself, to others around you, because that's what trauma takes away from. So if you want to know more about it, you can ask my details, and I'm here to help with it.
I myself did training as well, got out. Now went back to the institute when I was 2 years old. And it worked with that and so many more along the line. It was actually quite fascinating. Because when you're doing the training, you have to do it for yourselves as well.
Yeah, I've also experienced behavior training for honestly life changing. So yeah.
Yes. I had it on me first, but I went to the training. Why is this? I like talk that this is nonsense. This is not gosh, let me try it. And now I'm like, oh, wait a minute, onto something here. And then moved to Cape Town because I work now at BWRT headquarters. Because I'm saying this helps a lot more people in short space.
Yeah, that's good.
My name is Adriana.
Too soft.
And I'm a TRE provider, so attention and trauma release exercise provider. I'm a wellness life coach and a yoga body lift coach. So TRE is form of body therapy as well. And it is used to help people release tension and even deeply into the past. It's a set of 7 exercises that you will do in order to get the body into a fight or flight state, but in a very safe way. So it's a stress reduction technique that involves the tendering of the muscles, the tendering of the psoas muscles specifically. And it's a modality that can be learned and done. So initially what you do is you will have facilitated sessions so that the provider can bring you back into your parasympathetic state out of the freeze, then fight or flight, and then thereafter you are able to turn it on or in between. It was founded by Dr. David Pasali, specifically for veterans and suffering with PTSD. So a lot of clients come to me and they either feel stuck, they're unable to live life or go to work, or they feel tired, or like Samir was saying, they're just tired of speaking, and so they also just want to feel better. But also TRE and talk therapy works well together as well. So you have your bottom up therapy and your top down therapy. And so your bottom up therapy is your MDR, your TRE, and your top down therapy is your psychology, psychiatry, coaching. And so when the clients come to me initially, the first session is really just to listen to them, to hear where they're at. So if they're telling me they want somebody to hold them accountable, they want somebody to push them, I take the whole history into account. I see where they're at right now. I take the environment into account. And then sometimes coaching is maybe not what they need. They need body because they are already in survival mode. They're already in overwhelm. So now take that nervous system and come with coaching. And now they need homework that they're going to do for the next week. We need to push them and hold them accountable. They will either shut down and please never come back to me. Or yeah. That is actually usually before I did TRE with coaching, before I understood the nervous system, that's exactly what happened. And so when we're stuck in a survival mode, you can feel either, and I think, and a few other panelists also mentioned that you feel fatigued, you feel tired, you can feel dissociated at times, you feel feelings of helplessness and hopelessness. And low tolerance level is a huge thing. And so what happens is that we have three parts in the brain. It's called, you have survival part, you have the limbic system, and then you also have your neocortex. And when you're faced with a trauma or when you are being attacked, the first thing that responds is your survival brain, your reptilian brain, right? And so your body instantaneously tenses up. And then your body decides what the appropriate response is going to be. And so you will either fight the situation, will flee the situation, or if the situation is way too overwhelming, become overwhelmed with physical abuse. So, and then what happens is that your emotions that's happening at that time will be stored in the limbic system for later doses. The problem is when we don't process it at the later stage, and we are highly people. So it can be triggered by color, by a person, by a smell, by an emotion, even by what somebody's saying. If somebody's telling you to calm down, and you know you've done almost everything in your mind to calm down, you are able to do that because you can't talk somebody out of a sympathetic state, out of fight or flight. It has to be a body response. And so your neocortex is where all the rational thinking happens. But when you are being attacked, right, your neocortex is shut down. The problem comes when you get stuck in either your survival or in your limbic system, and then you're unable to make decisions from a point of view, or you're unable to even write your exams. You're unable to process information. Or if somebody's talking to you, you might seem they might seem a bit spacey or not really there. And so the only way to come out of that is to by a form of body therapy. Meditation works as well, breath work works. So anything that helps calm the autonomic nervous system. Um, that. So if we do not, like I mentioned, if we do not do any work to help bring yourself out of survival mode, you will keep fluctuating between release and fight or flight. And you won't come completely down to your kind of state. Won't come completely down into your grounded state. You might struggle to feel calm. And so a lot of people say, no, but I'm fine, I'm okay. Now the thing is with freeze, also a parasympathetic state. So you might think that you're okay, but actually you just shut down. And so theory evokes the trembling or shaking of the psoas muscle, and the psoas muscle lays deep in the pelvis. It is where a lot of our stresses is stored over our lifetime. If we are not allowed to shake, it remains tight and sends signal to the autonomic nervous system and to the brain that we are still in danger, and adrenaline will keep getting discharged. So only a relaxed psoas muscle alerts the brain that danger is no longer present and adrenaline no longer needs to be discharged. So the benefits of theory are directly related to the amount of times you do. So each time you do theory, you come down into your pace. And so your survival mode is shut down and you're able to go back into your meal and think rationally and make decisions from a calm point of view. So over time, once your survival mode is switched off and your neocortex is switched on, you are able to academically perform better, take in information much more, memory recall it much better, focus and concentration, maybe even with sleep, if you're struggling with sleep. And it has actually been reported that it's helped people with ADHD. And a lot of actual physical benefits. So tier E is for everybody from the age of 5 upwards. The only people that might be excluded from this is if you've had an accident in the past 3 months, if you are under psychiatric care. So if you are under psychiatric care, there are quite a bit of providers, theory providers that are psychologists and psychiatrists as well. But say, for example, you come to me and I will ask you to do you go in for psychiatrist. And if the psychiatrist is safe for you to get to do theory or in or then you're more than welcome to go in. That is also used in facilities as rehab facilities. Yeah. And then also, if you're undergoing cancer, if you're undergoing chemotherapy, because you've been diagnosed with cancer, that is a part of the indication as well, because TRE is a form of detox. So that's why they interfere with the medication. And if you're pregnant as well. So if you've had an established practice before being pregnant, and you've been doing TRE for a while, feel comfortable, you are welcome to do TRE during the pregnancy as well. So complications are there and happens about in 10% of people. So it's unpleasant, but it's not dangerous. So 3 things could possibly happen. You can flood. So it will be an overwhelm of emotions, or you might be overwhelmed by the pregnancy itself. You can freeze, where your body will physically, your muscles will stiffen, and you can dissociate. So you can even feel spacey, and the client might not even respond to you when they are in that state. So the aim of theory is to create safety within the body, connect yourself, and I shall be speaking about that as well. Sorry. Yumna was speaking about it as to create safety inside of your body. Because if you are unable to connect yourself, you're unable to connect your kids, connect to your family, spouse, partners. So that is the whole aim of the start creating safety within your body so that you feel safe enough to go out and connect to others. And so the only thing that I can leave you with right now is that all of these modalities that you've heard today works. I've tried almost everything already, just except BWR, which I need to do. But all of it works. And gravitate towards the one, move towards one that you gravitate towards. And once you choose which one you want, be consistent and show up, because we put years over inside of our bodies and generational. So it's not going to take just one session or anything.
Thank you to Lima for facilitating. She's got to run now. But yeah, we have the next half an hour to do some questions. But I'd like to maybe take 10 minutes just for the panelists to maybe engage with each other, the audience, to give feedback and to add on to what was already said. And I guess from my end, if I can start and put into perspective everything that our panelists have spoken about today, and how does it translate into helping a survivor at UTC. What I think is an important thing, just to take a couple of minutes, is that the reality is that the respondent or perpetrator is most of the time a fellow UTC student or staff member. So what that means is you're bound to see this person on campus, maybe not every day, but in some cases every day. In some cases, the 2 students share a residence. And yes, UCT has safety precautionary measures, no contact orders, suspension orders, but it's temporary. So it means only for a short period that that person wouldn't be in the shared space with the survivor. It's not a permanent fix. So these type of interventions can help the survivor, or even if you're not the survivor, but you're someone in that business, in that academic space, and you know of the situation and you've been impacted, these interventions can help you manage this environment better, manage yourself better. Because there's certain things that unfortunately we can't control. We can't control everything. We can't control when we're going to see the response. We can't control when we're going to hear something that someone's voice that sounds like the perpetrator and children, or see a similar car, or see a similar jacket, or see the perpetrator's friend, or see something on social media. Triggers for survivors are everywhere. And they can't predict when they're going to feel triggered. It happens per moment. And most of the time, survivor won't even tell you, even if you're walking with them, they may just wake up and see something and you to be wanting to go. and they'll sort of be in that flight or fright mode, like rush to their place of safety. And so we can't control everything, but what we can control is finding a sense of connectivity with ourselves and through these therapeutic interventions. So maybe just 5 minutes if either of us have feedback or want to comment on further information that was shared, and then we can open it up to the floor for questions.
I went to see my GP last week, and he was talking about the neural pathways and stuff, but they've now come upon this thing called molecular memory. And he was talking to me that it was something that had come to him who had been hypnotized for losing weight, right? And I said to him, how would that work with molecular memory? He said, it won't. So I said, why are you telling me it won't? He says, because you're trying to impose one memory on another. Molecular memory will always win. And I said to him, so how would molecular memory work? He says, for instance, if you want to lose weight and if you were 65 and weighs from 65 to 70 kilos, you were feeling good, you could eat everything, do what you wanted, and then you want to lose weight. But the molecular memory formation will not allow you to go back unless you change that memory through your BWRT. And will then say you felt good because you had no boundaries. So we need to rework that memory and bring it to something else. So that's why people battle to lose the first few kilos. Interesting data. But spoken shit about molecular memory.
Yeah, and I mean, if you think about it, that's when you look at violence or sexual and gender-based violence, it's a similar thing of this. So they feel like they can't forward. I get a lot of survivors that come into the space with me, and they're so fearful of what their life is going to look like because of this idea of like, once you're a survivor, and that's not true. That hopelessness is not going to last forever, and there's ways to rediscover yourself and to feel empowered and to feel alive. And through the different therapies, whichever one you feel as a survivor would be a right fit.
And what's important is understanding the severity of the anxiety. So earlier on, I spoke about emotions, but with the emotion. We just want to understand that there is something level. It's the energies in motion within and around you at that particular time. If you look at the energies of anxiety and severe anxiety, there's a solution. I mean, yes, it's talking about it's broken us to speak through the heightened vigilance, the apprehension, the sense of dread, the continual tension, ongoing pressure, stress. It's very, very threatening. And in keeping, in terms of umbrella emotional anxieties, understanding the perception, understanding the threat, the avoidance of the threat, the fear of the experience of the threat, and the perception of it. The perception of the threat is far more threatening than the threat itself. So there's so much of investment as a survivor of don't want to go there. I am petrified to go there. When you come to therapy, talk therapy, and other interventions, we are saying, no, please go there. We'll walk you along. We're right here because we want you to get there. Remember, the trauma memories is often stuck by the five senses. What did you hear? Smell, sound, sight, touch, and feel. And it's trapped in, within your brain, by the five senses. So a lot of the therapies, especially when you talk therapy, will say, so in your narrative style, telling a story, what did you see? What did you hear? What can you do in terms of touch, feel, experience? You're releasing trauma memory into a normal memory, integrating it, and you're also taking back your control. And all the specialists have spoken about taking back your inner personal sense of control. And when you do that, then the energies start coming down. So you don't have that strong emotional activities. You just start taking it back, you're reintegrating it. And what are you doing? You're working with your avoidance and really breaking down. That is absolutely important. So whether it's for therapy or the important interventions that we spoke about, in some BWRT is magic one, and it's really going to work, but it's helping you get to the avoidance of fear. And Yuna said it, I said it, all the specialists said it. It's normal to avoid. It's normal to feel frightened and fearful. What's not normal is the situation. Your feelings are normal, it's real. Okay. By taking into account that, we start breaking down the fear and we start working with the avoidance. Fear, because the avoidance and fear are a strong, powerful, aspects, because they then enable and refuel and rebirth the intrusive memories, flashbacks, the reliving, strong physical reactivity, strong emotional reactivity. So just to understand that.
And in a conversation that Paul and I had in prepping for today, you spoke about how survivors or clients at the state as well often come to us wanting an exit plan or support in terms of reporting, and that their focus is so rooted in their next steps for justice or for security or getting out of the environment that they often don't really focus on their well-being, or that even though you can be following a reporting process, or you can get a protection order, or you can be in a different environment, living environment from the perpetrator, you still have the trauma. And the trauma is not going to go anywhere in life, but from all time. There has to be ways, productive, healthy ways to work through this trauma, through all the senses I'm saying, all different mechanisms, shapes, and forms. So yeah, perhaps we can open it
Can I
up.
just add one thing? When you're undergoing the reporting process and the judicial process, remember your therapy must not stop. It's whatever modality you use. Sorry, your therapy must not stop because it has to be a due process. You can sometimes feel good. Oh, I'm going to win this case. And you have all engines firing to win it. What happens if a legal technicality comes into play? Who then picks up the case? What happens then? And the strange thing, Bhavani was talking about anxiety. When you work through all this stuff and you say, now what? I'm feeling like I don't have anything to worry about. And then you get this next phase when things are going right. You kind of have this feeling, if everything's going right, something will go wrong soon. So just please, once you've ended your sessions to do with the incident, don't abruptly stop therapy. Taper it off slowly.
So, Stephen, yeah, before we take questions, I just want to encourage everyone, before you leave, there's some sticky notes at the back to write something encouraging or any sort of saying that you have, and just to paste it on the square white sheet on the wall. That's going to go up in the survivor office. So survivors can get to read through it. And then I'd also like to ask you to please take a picture or something of that sort and post it, and use the hashtag UCT Ndawa 2022. Okay. Question. All right, can we go? Take you from like the friends coming back.
Louder, please. I can't even hear your story.
I think if you can stand, that would be helpful. It's a lot easier to project. Sorry.
I wanted to thank the panelists this evening for sharing this such information with us with its deep psychology. And I think many of us are not in the psychological field, and we're trying to understand this so we can go to the wellness route of it. And I'm thankful that our first panelists mentioned the traditional approach of understanding therapies or helping the survivor through the psychological route. And then it went down into what we said, doing that is accessible to many of us. And build a work organization. And the techniques you work with mentioned that there's the dreaming aspect of it that brings back flashbacks that they manifest in dreams. And I was wondering what could be one of the ways in which someone deals with those dreams that reoccur as flashbacks. They are good therapy, but they still go through that. And I'm much connected with asking last people the young about the how the pelvic stores all of traumatic experiences, what yoga class called chakra. How would you go about and to connect to the flashback and releasing each of the chakra traumas?
So exactly what we say now is that we have these energy centers in our bodies, and it could be physically attacked or sexually attacked. Different energy centers could be affected. And so it's not a coincidence that when you start trembling from the source muscle that lays deep into the pelvis. And it's called neurogen, it's involuntary tremors, but also known as neurogenic tremors. So it's something that's involuntary, that it's not something that you put in your mind. You'll see that the set of exercises that I'll take you through, or a provider will take you through, will automatically activate this trembling mechanism. And over the years, it's something that all of us has inside of our bodies, but it's been switched off because it's been seen as weak. So once you start trembling and shaking, your body actually starts over a period of time, not in modern positions, unfortunately, but over a period of time, your body starts creating homeostasis. And then over time, it actually creates balance. So if you check on my website, there's quite a bit of reviews from different people that has actually helped them on a physiological level. It has helped them with health issues. Myself, I have stage 4 endometriosis, and so there's nothing you can really do about it. But it actually has helped me cope with that debilitating pain because the cortisol levels low it down. So it's not so much stress that's involved.
And just would you encourage one to maybe do certain practices like breathing techniques before they go to sleep? Something that you do that.
So what I'm understanding is that the flashbacks are occurring in common dreams. The reason that happens is because I haven't processed it. So it's still there. It's not being processed adequately. It's still harmful and it's still maladaptive. So, and it's intrusive. That's why it happens in sleep. Sometimes when you're awake, get flashbacks. So how we work with that is, yes, let's try to relax those sleep. Sometimes it happens because you are still in survival mode. You are still activated. The brain is sleeping. It's still active in some parts of that. So when we have completely processed that, that's why we are actually article. Because we just need to do it. And that all falls away. Sometimes we find that as a result of your trauma, you then form a safety habit. So you don't go to this certain place or you don't talk to this person because it looks like that. And then we deal with the trauma, but you still fear to go that person. That's a new trigger that you created because of the trauma. And those flashbacks. And then you deal with that trigger. And you reprogram, okay, but it's just a person. And I can deal with it. And then you find the flashbacks completely
So through the process, and the flashbacks will not reoccur until the entire trauma has been. Some that will keep happening until we can have it. It's your brain saying, okay, what's happening here? What's happening here? Usually come in spurts. It's your way of trying to figure out what is happening. And because it's so traumatic, it's so engaging the emotions, it can't be integrated in a healthy way. And that's why this adult is helping. Help therapy, TRG, we help you in here as well. Which linked to our cognition, will help you to process it in a flashbacks.
I'm sure what was in India, I mean, that is, yes, no, it's big information, but it can read the concept of unsorted subconscious mind, and during your brain stage is activated at surfaces. But in terms of trauma, the thing is stuck there, and it's that thing to surface. And the only way to get it to surface is you take the power that is all the therapies. Then it becomes less threatening because you integrate in the trauma that's threatening you into the normal. Because it's going to use an escape, it's going to come to the teeth, it's going to come by a panic attack, there is going to be a flow. It's uncomfortable. That makes it just well.
Everything and everybody you talk about in that dream, I point out something that you're battling with yourself, and it's not really their issue. It's the issue.
I'm conscious of time. We might only have time for 2 more questions. Maybe we can take one there. Oh my goodness.
I think mine will be short.
Okay, go for it.
Yeah, it's for mosaic house. Yes. You mentioned that when you are dealing with clients, so the focus is not on the current problem, but their past. So that kind of confused me a little bit because hearing from all panelists, they kind of go to the past and still deal with the problem. So I'm kind of curious to find out how to do this.
So, okay, so when we work with the clients, the current problem, survivors, we work with the survivors, we work with the, we start off with what the current or problem at hand, what the challenges are. And through a process and through this journey and after sessions, it then surfaces that the survivor has unresolved trauma from past trauma that now surfaces and that sometimes have contributed to the current problems. And then we have to then work with way back past traumas.
Thank you so much for the panel. So just some feedback to say it's fantastic to see such a mixed panel with the methodologies that you guys are talking about. So maybe my first question is to ask, why do you think psychology departments refuse EMDR and some of those other methodologies in terms of training? Because they say something about the university and the kind of Western knowledges. So maybe you can say a little bit more. I know you're a therapist and you're doing it. So that's the first thing. The second thing is, I don't think there are any magic ones, not even EMDR. I've done 5 years of union therapy. I did EMDR and it helped me hugely. So I don't think there's any magic ones. I haven't, but anybody could sell us a magic wand to deal with the kind of violence that we're dealing with in South Africa and the world is selling us a pipe dream. So I think we really must be clear about it.
As close as that.
EMDR is helpful and it's a good methodology and it's a problem that psychology departments are not wanting to train people because it is a more accessible way to get people very quickly out of trauma, as you already said. But my question is also to the therapists and the forensic psychologists, what is the ethics of encouraging people to report into a legal system that re-traumatizes? We know that, we don't even have to research it. So what is the ethics of people keeping people in containment mode to perform for a legal system that doesn't work? That often you don't get verdicts that are successful And even if they are favorable, they don't amount to helping or healing people. So what is the dilemma there? And I'm sorry, last question. I have so many more, but what is the ethics or how do we think about supporting each other? If we do the therapies that help us, like EMDR and so on, I keep hearing people saying we must go back to a calm state and that hypervigilance is a problem. And yet we live in a country that is absolutely violent. So it's a middle class idea that we mustn't be vigilant, we mustn't be calm like middle class white people. I mean, I'm being facetious now, but we have to be thinking beyond just the therapy to resolve the trauma and also be thinking around how to hold each other, because we have to be vigilant, because the rates of gender-based violence and even just violence, it's just too much. So can we say something about that, please? It would really help.
I did the end. I'm so happy you asked the question because in an agile nervous system is called reaction, right? And with TRE, you're creating an agile nervous system. So after you've been doing TRE, this 36 is like the golden number where your body starts getting stasis. And that can happen over a period of 3 months or a year. It could be a year. My process was just so much slower. Right? And if you have an agile nervous system, you're able to pick up into the flight when you need it, or when you want to kick back down into your parasympathetic state of calming grounded, you also have that. And so a lot of the times I use this example with my clients, like it was me and my husband were driving once, and he said something that really triggered me, and I like went completely like red, and I shouted, and I was, for that crying, it's just like, what the hell? Like I haven't done this in such a long time. And then I said, you know what you said triggered me, which actually took me back to my feelings of abandonment. And within 3 minutes, I worked it out and I'm able to put out myself. So that's how theory. Let's just do. So thank you.
Your ethical question of process. Part of when I said the process, you have to mention all the stuff that happens during the case. And this is what we tend to do. I'm not going to train you how to be on the stand. I want to hear how you've been feeling. And I want to assess what you've been feeling and whether you should or shouldn't go to trial. It's the lawyers who then decide what's going to happen on that stage. Okay, so it's not a psychologist's dilemma, it's a legal dilemma. But you can imagine if somebody sits on the stand and says, "Please, management has not." What's going to happen? When you get to the point of reporting a violent incident, you're so fired up that you want to do the best you can to make sure that you get an eviction. So it's not really a psychologist's dilemma with ethics, because I'm not asking the questions. I'm saying, feel what you feel. And that, I think, is part of the way to get the person to understand the feelings evoked by the incident.
I think maybe that question is a little bit, could be applied to what I do at UCT as a support specialist. So I'm not the evidence leader, I'm not the specialized tribunal. I don't read the evidence, I don't do charge sheets, none of that. But my role is to be present for the survivor in that containment, in that immediate support throughout it. It's to be able to help them manage their expectations, to know that your first consultation with the evidence leader is going to be tough. They're going to go through your statement over and over with you. They're going to ask you questions. You're going to pull information after that session, but then you're going to have to write it again. So it's really about me not leading them into saying what they need to write into their statement, or leading them into saying this process is so long, or it's scary, I'm not going to do it, or to paint a picture of, it's an administrative justice process, it's easier than sentence. I have to be completely unbiased, but present, say to the survivor, this is what the process looks like. At this stage, today, this week, what support do you need? It's also from the survivor-centered approach. So I have to be available to that survivor from start to end. A courting process can take up to a year, but it doesn't mean the survivor is going to engage with me for that whole year. They're usually going to engage with me the first 3 months until they submit their statement. Then I'm not going to hear from them again until the case is then ready for the actual disciplinary hearing. And then they sort of reach out to me again. And then we look at, do you need a separate venue to write your exams because you're just overstimulated, you're just hypervigilant, and you need a contained space? Do you need me to be with you at the actual hearing in a supportive capacity? So I'm just there physically for you to see as a safe person, because the way the specialized tribunal will engage and speak to a survivor, yes, compassionately, attentively, but they still it's still using legal jargon. And so I'm the same house. I'm the physical safe house for the survivor throughout the process. And likewise, in a SAPS process, then we look at, would you like to go through a separate entrance where you're not waiting with the broader or general public? Do you want me to come with you physically? Some state prosecutors allow me into the consultations, others say no. If the case is happening at Central Cape Town, then we can also make use of the rape crisis court to be with the survivor when they testify. If it's Weinberg, we can connect with Mosaic. So ethically, I would say that we need to do everything in our power to make the special accommodations known and available to the survivor. Sometimes it can't be done, but not because we haven't tried as the OIC, but because of other departments, chairs, proctors, things, state prosecutors, and so forth. But our role is to always think outside the box in how to better navigate the process for the survivor.
I just want to try and answer it. I think for us as students, to be served everybody. I think in terms of the medicines, that's to the seeds, anything else. So when your client or patient comes to you, in terms of the presenting need or challenge, you always act in their best interest. You cannot delay treatment. That client and patient is going to disintegrate and land up impossible. So you work with the client and conscientize them and sensitize them, and when you go to court, you're going to get to a place where you're going to have to reflect as if you will be experiencing trauma, which is what serious trauma. Justice gives the survivor into doubt. Okay, we know that. But I think in terms of the medicines, the best interest of the client still stands. You work with them, you conscientize them. Because therapy itself is opening up old wounds, so you conscientize that it's not going to be this. You're going to have to go down that path. So you might feel contained, but you don't ever delay contained another person. If there is an agenda, it is your responsibility as a parent.
All right, I think we can take one more question.
Yeah, thanks. I'm not from humanities. I'm a scientist. From BBB. But I have read a lot and I'm interested in this stuff, otherwise I wouldn't be here. My main question is actually one that all these complicated abbreviations, I typed them down so I can look up more about it later. Is that a standalone, or is that like a start where you get into a state where you can use the other therapists to really digest what you've been doing or what has happened?
Okay, so EMDR was, I'm going to say a CBT component, call it that. It was cognition as well. So it helps to reframe that in the traumatic experience. What I have found is sometimes it's useful or it's needed to use these modalities in conjunction with, for example, CBT framework, therapy, and so, and in that way, I heal inner child work. So healing the inner child, kind of traumatic memories from childhood. It accelerates that kind of process, and so using that. But if it's for trauma, if it's for phobias, if it's for those kind of things, I usually use the step where the trauma happened today, yesterday. I'm using cases where the person was kidnapped or mugged and shot and came to see me the next day, using immediately or later, depending on what has happened around their life. So it can be used either or in conjunction with therapies, both EMDR and EMDR can be a good addition to normal talk therapy. Sometimes you find they need to release this trauma first, then we can work with it. So works very well together.
Okay, yeah, because you gave a little bit the impression that when you use your brain, whatever, you don't need anything else. But
Well, for trauma, I don't use it. So
Okay.
trauma phobias,
Mhm.
I don't use any other of that, but yeah.
It also depends on the person. So
Exactly.
with theory, it's a different kind of clientele. So some clients only does theory and it helps them out. Had a client that is going to be quite self really, but they felt safe enough to go into their private self.
Yeah.
And then other clients use talk therapy along with theory.
And I think if I just bring it back to the context of survivors again, what in a reporting process, like Rita said earlier, you don't stop therapeutic work, but what would be important is then to assess what type of therapeutic work do you need? Because BWRT or EMDR is going to distance the emotional experience from the memory, which is going to work against you in a trial or disciplinary hearing. So in that case, the blend of the two at different points in time would be recommended. So, and that's why I said at the beginning, it's about, sharing this knowledge that we as support carers and survivors who are listening in can recognize that it's not only one therapeutic intervention, there's many, and it's trial and error, right? It's about what fits with you and where you are at and what's going on in this healing journey or recovery process. And why the emphasis is on mental health is because we cannot guarantee that receiving a guilty verdict is going to make a survivor feel healed or recovered. It acknowledges and helps acknowledge the trauma, but whether it's guilty or not guilty, the trauma still happened to the survivor, and they're still going to have to work through that. So yeah, and I know we're running out of time, but before anyone leaves, in your brochure, you'll see all the speakers' details, the contact details, their therapeutic website. So it's also online so that you can make use of it. We are at 3 minutes past 6, so I'm going to do one last round of any final feedbacks to the audience, and then we can wrap up.
I wanted to ask Samina, any BWRT techniques from performance anxiety or panic attack past you?
Yes.
I've got to make use of it.
It's the same process. Same process. and I
Anything that you can
use-
offer to
So-
students right now?
In coping, basically, it's when you have a panic attack or you have performance anxiety, it's about being activated, being in your limbic system, being in survival mode, and finding that you are in fight or flight. What BWRT helps you to do is it helps you to visualize that, yes, I am anxious, but I can manage it. So that's the difference between I'm getting debilitated by my anxiety and I can't write this paper. So I prepare well and I get there, I'm like, I have a client currently who doesn't eat the day before she writes a paper. She didn't even know she wasn't eating until someone in her family pointed out to her. So she's got a test, say, on the Wednesday. On the Monday, automatically she stops eating. She doesn't even know she has some fluids, whatever, until the Wednesday morning when she was going to write a paper and she fainted. And she says she was so anxious because she hadn't eaten, just studied. So we put the eating right for that, the anxiety was still there. So healthy diet, adequate sleep. Also, I am prepared and I am going to be able to write this. Breathing is very important. So any sort of anxiety, breathing is very important. If you go to the BWRT specific protocol, it takes about 25 minutes to do. it allows you to create those different patterns. So you imagine yourself going to write paper. It's a specific process, and then you finish the paper. This person that wrote, but I managed all of my things that came out. And we try to create a replacement response on when you are feeling when you write a paper. The process is very hard to say, give you tips on that because it's very brain-based. We have to do it in a group setting and go through the process in stages that it needs to, and then you find relief after. But when you are in butterfly, remember that you need to calm your system down. Doesn't mean not be vigilant or you're not going to worry about stuff, but it means that you need to reduce that activation so that you can be your frontal lobe can be activated. You can produce results, you can be rational, you can think about things. And this is where arting helps you in just cutting the reaction down and be able to manage the paper. Yes, you have anxiety, but I can manage this. That's the takeaway you have to do. It's going to be anxiety. Yes, it's hard, but yes, I can. And if you get a panic attack, obviously, before panic attacks, breathing is important. Because that's the switch in telling your prefrontal cortex, listen, there's no danger here. I'm okay. So really activate that, put the switch back on, say, calm down. That, when you get that big boss brain, I like to call it, back into action, you can start thinking rationally and you can calm it down. When you're in the living system and that's activated, there's no rational thought. So the activation keeps going on, and that's no way. You need to keep breathing deep, intentional breaths, mindfulness, deep, intentional breaths. Bring yourself back to 5 senses. Where am I here right now? Can I see 5 things? I can see 4 things I can hear, 3 things I can touch, 3 things I can taste, 1 thing I can smell. You do them in any order, but it's reorientating you to the present, here and now, and then you find that you can regulate yourself and then get better. If you do reorienting performance anxiety, like people, public speaking is a huge thing. I mean, doctors, lawyers, some expert witnesses as well.
So just, and also, sorry, just for me, Samika mentioned grounding technique. So 5 things that you can see, 4 things that you can smell, 3 things that you can feel, 1 thing that you can taste, etc. It's a grounding technique. So if you Google grounding techniques, it's very quick. If you're sitting in your exam, or you're sitting with a test, or you're going in for an online exam, it's something that you can do. When I'm hearing you say positive affirmations, visualizations, reframing, shifting. So reframing how you see it, shifting energies, shift your energies, and then build the stress tolerance. How to tolerate hold and contain the negative energies.
No, that was fine. I just want to add on that after you've been doing TRE for a while and your body is starting to get homeostasis, when the new stress is putting back on your body will automatically start indicating to you when you need extreme relaxation. So you might find that your arm or your hand or your leg might automatically start trembling, because now that trembling mechanism has already been activated and it knows that when you stress put back on the body, it knows that then get relief.
And I think just to end off, I know there was the idea of like how do you calm yourself down, and it's not this unrealistic idea of be calm and like be totally chill with no worry, no thoughts. Like it's not that kind of calm. It's a realistic. Yeah, it's not utopia. It's a realistic feeling grounded, feeling like in control, knowing that you can get through whatever was stressing you. Not an unrealistic, I give myself to feel calm like I'm on a holiday type of calm. It's more realistic and practical.
Yes, it's creating capacity to deal with life every day. That's what it is. Yeah. It's calm in the way that it's not activated, so that the window of tolerance is not activated. There is capacity there to deal with things, like the empty cup. So you create capacity, and now if life throws the curveballs, it will. You're able to deal with it and help functionally. That's the calm.
And then lastly, just thank you, panelists, for sharing your time and your expertise with everyone. And it's greatly appreciated from the OIC faculty. If you can, it's only 5 questions, and then note on your lanyard, there's a QR code. And that goes to actually the reporting page to me directly. So if you know the survivor and have this on you, you just scan it, We fill in their details and I'll reach out to them within 24 hours. It's not a reporting process. You still need to initiate an export. Okay, thank you. Yes.
I don't know, that's what we had. Yes. But you have.
Are you familiar with this building?
Sorry?
Are you familiar with this building? Yeah.